side, which is typically a little bit more dangerous. The ones we're talking about today are specifically aneurysms of the aorta, which can happen in the chest or in the abdomen. Aortic aneurysms are more common in men than women, and they are more prevalent the older you are. The stereotypical person that they talk about in school is the old white man that smokes. You picture those up on a picture one on the hallway out the 3 North if you want to see what that looks like. Little guy sitting there with a cigarette. I don't know if y'all noticed it. These are typical patients. So this is a typical infrarenal aortic aneurysm. You've got your renal arteries here, an aneurysm of the distal aorta. This one also has an aneurysm of the iliac artery. Most aneurysms are asymptomatic. They're usually found on imaging studies for something else. The urologists are usually the ones that find most of them because they get these non-contrast CT scans looking for kidney stones and they find aneurysms. On examination, to be perfectly honest, our patient population, you're probably not going to feel them very well. Okay, so, but if you do have a pulsatile mass from the umbilicus to the xiphoid process, it may very well be an aneurysm. The aorta bifurcates about the level of umbilicus, so they sit right here. You may hear of bruit. Again, within our patient population, you very well may not. Usually done for something else. Symptoms, when an aneurysm starts to be symptomatic, it is usually described as an abdominal pain or a back pain. People describe it different ways. Some people say a sharp pain, some people say a dull pain, some people describe it as a ripping or a tearing sensation. You can have aneurysms that will embolize plaque to the legs, blue toe syndrome, or a trash foot's another way to describe it. Where you just have blue cyanotic toes from microemboli. You may even still have palpable pedal pulses if the emboli are small enough that they go all the way down and lodge in the digital vessels. That's typical of this. It's rare, but it can happen. Aneurysm rupture, that's the big thing we want to prevent. So when an aneurysm ruptures, regardless of the improvements in surgical technique, critical care, those kind of things, there is still an 80 to 90% mortality rate for a ruptured aneurysm. That includes people that rupture in the hospital. So there are a couple of different types of rupture. What they're calling here a posterior rupture. The aneurysm, the aorta is in the retroperitoneal space, so it's not in the abdominal cavity, it's behind the abdominal cavity, it's next to the spine. So those tissues can contain a ruptured aneurysm for a period of time. It's variable, but they can sometimes last for a few hours with a contained rupture. They will hurt, they'll have back pain, abdominal pain, they may have some ecchymosis on their flank. At the point when they start to go really downhill is when they rupture into the abdominal cavity, what they're calling an anterior rupture. So the abdominal cavity where all the GI tract is, that is a big potential open space. So when you rupture into that space, you can lose your entire blood volume into that space in just a few minutes. These are the people that come in with a tense, distended abdomen and they're hypotensive. Typically, when you open their abdomen, they bleed out and die within a minute or two. And there's really not much you can do to save their life. That's a very devastating outcome. Collaborative care, obviously we're all going to work together. We want to get the best outcomes we can for our aneurysm patients. And I didn't mention it before, but this is all part of getting a AAA Joint Commission certification. So we're working on systems, processes, and the delivery of patient care specifically for AAAs at this point. So the collaborative care, the ER has to diagnose it. We have to treat it. You guys have to take care of them. And we just have to do a good job all around. For a asymptomatic aneurysm, obviously the best thing for the patient is to find it early and treat it before it ruptures. What we typically do in the office is we follow them until it meets surgical criteria for repair. Every 6 months to a year, depending on size, with an ultrasound. So to repair an aneurysm, the criteria are going to be absolute size. 5 centimeters is usually what we look at. That is the standard for men. For women, there were not many women involved in the AAA trials that were done, so it's generally accepted that you can fix those at a smaller size. The women's body habitus is generally smaller than a man's. The size of the aorta may be a little bit smaller, so another criteria is if the aneurysm is more than twice the size of normal adjacent aorta, then you should fix it. Also, rate of growth is another indicator. So if it grows more than 5 millimeters in 6 months or a centimeter in a year, it needs to be fixed regardless of size. Now, when you guys get a nursing assessment, you guys do a history and physical on these people. The big thing we need to, cardiac pulmonary monitoring, y'all do that. One of the big things we need to make sure everybody's clear on is lower extremity vascular problems and neurovascular checks for the extremities to make sure there's no confusion. It seems like there has been a little bit of confusion what I mean by neurovascular check as opposed to what a neuro check may be in other settings. So, establish baseline data to compare post-operatively. You should have baseline data from seeing them in the office or the ER, but post-operatively there should be dictated in the op note what their pulse exam is afterwards, or should be written on the procedure note or somewhere in the chart what their pulse exam was at the conclusion of the case. That's one of the criteria that we're going to be using for this certification, so we have to make sure that's followed throughout their course. So when you have somebody that's got a symptomatic aneurysm per se, indications that they may have gone to rupture, pale, diaphoretic, tachycardic, worsening abdominal pain, back pain, basically signs of hemorrhage. One of the things post-operatively, obviously you need to make sure they have normal perfusion, which means they need to be normovolemic. They need to have adequate IV fluids, have to be transfused adequate blood products, especially if they were ruptured. Intact motor and sensory function, that's getting into the pulse exam of the extremities. So when you have a leg that is not getting adequate blood supply, one of the first signs that that leg is ischemic is altered sensation, specifically altered light touch sensation. So getting into the neurovascular check for the extremities, what we're looking for is for them to have normal light touch sensation in all the nerve distributions of their foot. So the one that is most sensitive, the earliest sign of an ischemic foot, is going to be impaired sensation in the deep peroneal nerve distribution, which is between the big toe and the first toe, at the base of the toe. And that's the first one that's going to start to have issues. From there, we'll go to the peroneal, which is the rest of the top of your foot, and the bottom of the foot. A later sign of ischemic changes, even if the foot's not modeled, even if it's just cool to the touch, would be impaired motor function. And that is a later sign. If you have impaired motor function, you generally need to intervene now, or they're going to have permanent neurologic deficits, which may mean they may permanently lose motor function of the foot. From there, the next step is going to be gangrene. All right. As with most everything we deal with, there's always room for improvement about general health, especially for these people that use tobacco products. They're not healthy otherwise. Our general patient is not very healthy, especially in the vascular world. Cardiovascular risk, modifiable risk factors such as diet, exercise, cholesterol control, type diabetes control, all those things are part of their overall management. Those things will also help ensure that the graft stays patent as long as possible, which is also very important. Obviously, when you've got family support, it's good to involve them. Pre-op teaching, we do that in the office mostly. For an open repair, we may or may not use a valve prep. Obviously, there'll be NPO. We try to get them to use Ibiclins the night before. For the emergent section there, when somebody ruptures their aneurysm, it's just like a trauma. They get a lot of fluid. They may get blood products. With an open repair, even an elective repair, the dissection is so extensive around the aorta, they're going to require a lot of fluid post-op. So that's just part of the ICU management. Obviously, you want to maintain the graft patency. Normal blood pressure, we do that. We don't really use Swan-Ganz catheters very often. CVP monitoring, we will do that intermittently. But in general, if they have a normal blood pressure, they have normal urinary output, then they're generally thought to be normovolemic and adequately resuscitated. If there's lab abnormalities such as ABG with a base deficit of -4, that's different. But those are the things you want, which is what we do here for critical care anyway. Obviously, you want to make sure that we don't have any significant infections. For all of our post-op patients, there should be perioperative antibiotics that are continued for the first 24 hours after surgery, and then they have to be stopped at the 24-hour mark. If you exceed that 24-hour mark, you get dinged by joint commission. If they have signs of an ongoing infection, that's different. Body temperature, white counts, nutrition, that's all just routine, what we're already doing. As far as NG tubes for an open repair, they're all going to have an NG tube. They're going to have an ileus that's going to last 3 or 4 days. For an endovascular repair, sometimes those people will get an ileus anyway, even though we didn't open their belly, but they rarely require an NG tube. Passing flatus is a big sign that they're getting their bowel function back. Bottom line here, manifestations of bowel ischemia. That's a complication that we don't talk about much here. When you do an open aortic aneurysm repair, you have to ligate the inferior mesenteric artery, and you make a judgment call as to whether or not you should reimplant it into the graft. When you do an endovascular AAA repair, you cover the inferior mesenteric artery, and it will most of the time clot off. So you can cause decreased perfusion of the gut, specifically the colon, the colon, descending colon, and sigmoid. So the first indication that somebody may be having ischemic bowel is diarrhea. So you have somebody post-op day 1 open or endovascular AAA repair having a lot of diarrhea. That's something we need to know about, because we need to get GI and put a scope up there and see if they have any ischemic bowel. If they do, a lot of times we can treat it with just NPO and IV antibiotics. If we can, it doesn't resolve, then they'll have to have a colon resection. Neurologic status, that's typical, pretty straightforward. The pulse exam, we kind of went through that a few minutes ago, but as far as documenting the pulses, if someone has palpable pulses, that's easy enough to feel, easy enough to document. You have to be careful though, because some people you'll think have palpable pulses, you're feeling your own pulse. If you put your finger on this table just right, you'll feel your own pulse. You know the table doesn't have a pulse. Generally what I do is if I have to search too hard for a pulse, I go get the Doppler. Because if you're trying too hard to find something, you need a little bit better information. So with the Doppler, you're going to look for Doppler signals behind the ankle, which is the posterior tibial. You look for signals on top of the foot, which is the dorsalis pedis. The dorsalis pedis signal is usually between the tendons to the first and second toes. On most people, you can see that. So that's the general area it should be. They should be marked coming out of the OR. So you should know about where they're at anyway. But the marks are not always completely accurate. Our patients are not going to always have Doppler signals in both of those arteries. That's just the way they are pre-op. If they have a good signal in one, that's usually adequate. But the key thing here is if there is a change in the exam that is different from what is documented, we need to know about that. So I'd much rather y'all call me and say, well, the note says we had a dorsalis pedis after the case. Now all I can find is a posterior tibial. I'd rather you call and tell me that than you not call me and there be a problem. Renal perfusion. That's less of an issue with endovascular repair because the device should be deployed below the renal arteries. When we do an open repair, you put a clamp on the aorta, sometimes above the renal arteries, which will cause renal ischemia for the period of time that the clamp is there. Or if they've got a lot of plaque in the aorta and you put the clamp below the renal arteries, you can break some of that plaque off. It can't go into the renal arteries, can't embolize. Renal perfusion also is heavily dictated by their perfusion status. If they're not normal volemic, they're hypovolemic, then they're going to have acute kidney injury, may have some oliguria. So it's real important to keep them normal volemic and watch their urine output. Home care, that's just education that we do for our patients routinely. Obviously, they get surgical wounds. We don't want to do any heavy lifting. We don't want to do any crazy stuff. You have to spell it out to some of these people. They'll do. If you don't say you can't go bale hay, they may do it anyway. But they have to be counseled on signs of infections, signs of limb ischemia, signs of any surgical complication. We keep the bar very low. We try to tell them anything you're concerned about, you need to call us. The expected outcomes. So the expected outcome is that the graft will stay patent, that their aneurysm will be excluded, and that they will do well long term. So for an aortic endograft, that graft should stay patent the rest of their life. They will require lifetime follow-up with the surgery office. For an open repair, those grafts should also stay open for a very long time, especially if they stop their smoking and they address their modifiable risk factors. Those are the biggest things they can do. All right, now the aortic dissection, we're gonna switch gears a little bit here. Dissection is a little bit different animal. So the aorta is made of 3 distinct layers. You have your intima, which is the inner endothelial layer. You have your media, which is the muscular layer, and you have tissue, which is the connective tissue that surrounds the aorta. A dissection is where you have a tear in the intima. So that inner layer has a tear, and you can get blood flow between the intima and the media. So you basically have 2 flow channels now in your aorta. The one that's in the aortic wall doesn't necessarily have a free place for it to go back into the main flow channel. So what it'll typically do is propagate down the aorta. So you may have a tear, just below the subclavian, but the dissection may extend all the way down. Sometimes it goes all the way down into the iliac arteries. So when you have 2 flow channels, and you get one channel that does not have a way for the blood to get back in, the pressure in that false lumen is going to be higher than the pressure in the true lumen. So it's going to compress the true lumen, which can cause end organ ischemia. So If the true lumen cannot provide adequate flow to the visceral vessels, the renal arteries, the superior mesenteric and celiac arteries, then there will be ischemia at those end organs. Sometimes the dissection will actually perfuse those arteries, though, and it will sometimes re-enter and perfuse them, which just makes it more complicated when you try to repair it. So there are two types of dissections. The easiest classification systems are type A or type B. Type A is ascending aorta, type B is a descending aorta. Type A is going to be an open surgical repair. It requires a graft sewn into the basically the aortic root. A type B we can fix with an aortic endograft most of the time, but they can be very complicated. They can be very difficult, and one of the life-threatening complications of fixing this with an endograft is if you put the graft in here and then you get a retrograde dissection that goes to the aortic root and it compromises flow to the coronaries and they pass away on the table. There's no coming back from that. I think that I've already kind of gone into. So when someone has an aortic dissection, there are several celebrities out there that have died of these, and it's always a challenge for the ER to diagnose it, because when they come in, they seem like they're having a heart attack. They're having mid-sternal chest pain, mid-scapular back pain, and the impetus really is on them to help sort that out. So what you can sometimes have is they've spent a few hours working on this chest pain workup that's been negative, and it's not really their heart, it's this. So these can be very dangerous. Kind of like the AAAs, they'll complain of a ripping or tearing sensation, mid-scapular back pain. It's usually sudden, severe pain. Most often in people with uncontrolled hypertension, people that take cocaine, people that take those kind of drugs. They can have uncontrolled hypertension, you get a tear in your intima, and you've got a dissection. It can cause cardiac tamponade, which can be lethal. If this ruptures, just like when you have a free rupture in the abdomen into the abdominal cavity, if this ruptures into the chest, that's a big free space. They'll bleed out into their chest in just a couple of minutes. All right, diagnostic studies, EEG, EKG, MRI, that's not really something we're going to do here. A CTA is a more common study, which is going to be what we're going to use for operative planning. So the treatment for a dissection, ultimately they're going to require some type of repair. Almost uniformly, we start with medical management, which is to lower the blood pressure. For a lot of these patients, if you lower their blood pressure to an acceptable level, they will become asymptomatic. So it's not unusual to have somebody with an acute dissection of the thoracic aorta. You put them in the ICU on a beta blocker drip, their pain goes away, and then you get their blood pressure controlled long-term with oral medications, and you will follow them as an outpatient. And as an outpatient, the aorta will probably degenerate into an aneurysm, and when the aneurysm gets large enough, you'll do a repair, either with a stent graft or with an open repair. So that's the typical thing. Now, one of the other concepts is important, not only with this, but also with AAAs, is the concept of permissive hypotension. So what you're looking for, your goal is to have low blood pressure, but it's a balance. So you want your blood pressure lower because it's going to decrease the shear pressure on this dissection, but also for a rupture, lower blood pressure, probably less bleeding. But you also have to maintain tissue perfusion. So in these patients, it's okay to have a blood pressure of 80 to 90 as long as they're mentating normally, their mental status is normal, and they're making normal urine output. If they're not doing those things, you probably need to bring it up a little bit. Treat conservatively, we already talked about that. Surgical therapy, if you lower the blood pressure and they're still having complaints of chest pain, they have to go to surgery. All right. I'm not getting too much into the preoperative positioning. And blood pressure control is got to be routine with these patients after they leave the hospital. So I've got some graphs up here to show you guys. Just we do an open repair of an aneurysm. You've got an aneurysm sac. You typically, the ones we do here, you have a normal segment of the aorta just below the renal arteries, then a dilation where the aneurysm is, and normal aorta below. So when we do an open repair, we'll put a clamp on the normal aorta above the aneurysm, and then below the aneurysm to repair basically the tube section that you filleted open. Then you'll close the aneurysm sac back over the top of the graft, so So on all future imaging studies, there will still be an aneurysm there, but there'll be a tube graft inside the aneurysm that is containing the blood flow. For an endovascular repair, so these grafts are for the chest. So these are just tube grafts for a thoracic aorta, a thoracic aneurysm, or a thoracic dissection. So these are waterproof. They've got metal stents, metal rings, and this material is waterproof material. So when you have an aneurysm, you need a normal segment of artery above the aneurysm and a normal segment below the aneurysm, so that these things can get up a watertight seal. So if you have normal aorta below the renal arteries, for example, in the abdominal aorta, and you put in an appropriately sized graft, it'll seal, and blood flow cannot get between the graft and the abdominal, or between the graft and the aorta. If you have a normal seal below, same thing. So blood can't go around the graft; it's forced through the graft, and it depressurizes the aneurysm sac. Okay. So for abdominal aortic aneurysms, these look a little different because it's different manufacturers, different types of grafts, but they do the same thing. So for one in the aorta, in the abdomen, you've got the iliac arteries to contend with. It's not as simple as just putting in a tube graft. So you've got two pieces. You've got one piece that looks like this, and one piece that looks like this. So this is all in one catheter. We put it in right below the renal arteries, and we deploy it down to right here. When this limb springs out, then we run a catheter up through there and put in another piece here, and it goes down into the iliacs like that. And finish deploying it, and you're done. Okay? So basically we build it inside the aorta. And then there's another type that you may hear. We don't do this often, but this is designed specifically for ruptures. So this is called an aorta uniiliac device, or an AUI device. So this is designed to put in the aorta and have one limb going into one iliac artery with no attempt to put another one down the other side. So the way this works, you've got a ruptured aneurysm that's bleeding. You deploy this right below the renal arteries. You run this down into the iliac artery on whichever side you put the catheter up. Then on the other side, you put a plug of this iliac artery back leading into the aneurysm sac, and you have to do a femoral bypass graft to restore flow down the other leg. So what this does is it rapidly seals off the aneurysm, which is the goal. So that stops the hemorrhage. Then you can deal with the ischemic leg by doing a fem bypass. So it's much quicker. There's less blood loss than trying to build up that other graft inside the aorta. These are just two AUI devices. They're different manufacturers, but they do the same thing. This one's got hooks on it, so be careful. It will stab your fingers. And those hooks on there are the suprarenal fixation. So you put the graft at the bottom of the renal arteries, and those middle struts will spring out and affix to the aorta to help prevent the graft from migrating. So this morning the question came up, what are some specific things about endografts that would be complications? All the endografts on the market today do have a risk of moving. Now that's very rare, and it's very low risk. But graft migration is something the FDA looks at on all the grafts that have come to market. I've not really seen any that have had any significant migration unless the aneurysm continues to degenerate and the top of the seal below the renal arteries breaks because the aneurysm can continue to enlarge, and then the graft may fall down into the aneurysm sac. The other thing is called an endoleak, where you have blood flow still perfusing the aneurysm sac despite having the graft in there. So the aorta is just like any other blood vessel. There's going to be branches off of it. The ones that we deal with most often are the lumbar arteries that come off the back. Also, the inferior mesenteric artery is at the bottom of the aorta. If that thing doesn't clot off, then it can cause backfilling into the aneurysm sac. A leak that is caused by retrograde blood flow through a branch into the aorta and into the aneurysm sac is called a type 2 endoleak. Those are not particularly dangerous unless the aneurysm starts to enlarge. So if the aneurysm stays the same size or gets smaller, then the indication is that the aneurysm is adequately sealed off. But if it starts to grow again, then you know that the aneurysm is repressurized. You have to do something about that leak. So that's one of the reasons these people have to follow up for the rest of their life. They have to get imaging studies for the rest of their life. There have been reported instances of people not following up, having an endovascular repair, and coming back with a rupture because these leaks weren't identified. So other types of endoleaks, the ones that we really worry about are the type 1 and type 3 leaks. So type 1 endoleak is where your seal either above or below the aneurysm is broken down and you no longer have a watertight seal. And so you've got backfilling of arterial pressure into the aneurysm sac, and it repressurizes. Those have to be fixed. The other one is a type 3, where the graft may come apart, where the two pieces may not stay together. Very rare, but I have seen it happen. Or if there's a hole in the graft, as if there was a manufacturing problem and there was a hole in the graft that should not be there. That's a type 3. Those things, if those things are identified in the OR, then they're fixed in the OR before the patient comes out. If those things develop afterwards, then you still have to go fix those. Just another reason why people have to follow up long term. Another potential complication is a graft infection. That's with open or percutaneous treatment. If the graft is infected, it has to be excised, which is a pretty morbid procedure. So you have to